Thank you, Dr. Khanna. Really great effort in this time. So you have been given the topic clopidogrel resistance, fiction or reality. I will be talking in two parts. One is a real study which has been conducted in Kolkata in my previous hospital, and then followed by a case. These two cases will leave several questions after the session is over, and we need to think about it, that what should be the solution. So one of our colleague in School of Tropical Medicine wanted to do a study to see that what is the evidence that clopidogrel resistance is there by a genetic analysis. So this is on the study which has been conducted by from School of Tropical Medicine on the evidence that what is the percentage of patient who is having this problem of clopidogrel resistance. Now, clopidogrel resistance can have certain genetic mutation effect, spicing effect, new stop codon. So these are the theoretical discussions. But more importantly, what we did is that in collaboration with School of Tropical Medicine, we took the patients who suffered a STMI, non-STMI, or underwent a angioplasty, and who has been receiving clopidogrel or other antiplatelet agent. And what it was done, a 3 milliliter EDTA blood was being taken, and there was a assessment for this genetic mutations of CYP to C19 enzyme. As Srinivas has already mentioned about this problem of metabolism of clopidogrel, where this prasugrel and ticagrelor mostly bypasses this step. Now, clopidogrel has been a victim of either rapid degradation or inadequate conversion to a prodrug. So what they have done a PCR and RFLF to see the evidence of resistance of clopidogrel. Now, there are three groups. One cross-sectional group, which they have taken randomly in the OPD who have underwent bypass surgery or had a myocardial infarction remotely, and they look for their clopidogrel resistance. The other group, which have underwent a PCI, and but they have been closely followed and they didn't do any clopidogrel resistance for these patients as a control arm. The third group are those who have been on clopidogrel after intervention and their clopidogrel resistance was done. So the difference between group 1 and group 3 is group 1 is randomly coming patient without an event in the hospital, so-called, but receiving one antiplatelet drug for some reason or other, either a myocardial infarction, stroke, or maybe angioplasty. Group 2 is a patient's group who are being taken without a clopidogrel resistance assay and been given antiplatelet as of desired by the operator. And the third is the antiplatelet assessment in patient who had a angioplasty already done. We kept all the patients except patient below over 70 years because some of these patients may be receiving prasugrel. And we just took the blood report and tried to assess that what is happening in the genetic environment. Obviously, the patient who are on steroid or post-transplant or having a life expectation less than 1 year has been excluded from this trial. Now, what was being done that all these three group has a number of around 60 in total number, and what we found grade 3, that means who had a angioplasty, among 27 of them had a poor response to this genetic clopidogrel, showing this genetic mutation badly. Now, what does it mean translate into clinical events? That's most important thing. So what has been studied over next 18 months that group 1 who randomly came with clopidogrel or aspirin on their therapy, 5 of them have developed a myocardial infarction by this time. And group 2, where we have not tested anything, there are also 3 patients who have developed MI. Group 3, where we have changed our antiplatelet practice after a PCI following a index procedure, we found numerically late number of AMI, ischemic stroke, although happened in 2 of the cases. These are so the numerically it is very difficult to say because it's a observational study, it's a thought-provoking study, but to take a message that there is really an area of clopidogrel resistance which exists in the clinical practice. Which group of patients are suffering from this is been assessed in this particular study by genetic testing. Now, genetic testing doesn't mean that platelet reactivity is abnormal. So that also a catch in this. So I just wanted to show this slide because this is a real-time assessment of our community patients, and where we have found that changing the antiplatelet may have numerically decreased the chances of ischemic event, particularly myocardial infarction, but without significantly increasing the measured bleeding. There is no hemorrhagic stroke actually in the patient who have been receiving ticagrelor or prasugrel because of clopidogrel resistance. With this, I end this short observation thesis sort of thing and show you a case which is again a thought-provoking, and I think that many of us has been gone through such trauma. Now, on 28th August 2017, almost 3 years back, I was surprised when a young patient who presented with acute chest pain, and he actually visited me a week before, and he was perfect, and he was getting a nonsense bleed here and there, and he was on dual antiplatelet, aspirin 75 and prasugrel 10 milligram. So I told him that it's a long time, you are on 2 antiplatelets, so switch over to aspirin only. And he has a angioplasty of left anterior descending artery in October 2014. So theoretically speaking, in the numerical values of month, it is more than 36 months. And after 7 days, he has been referred with this ECG and chest pain and positive troponin T. A echocardiogram was done in emergency, which shows a LV dysfunction. We did a angiogram, and we can see the stent, and it is occluded from the ostium. The other artery is surprisingly still good. Now, let's analyze what wrong I did at that time. So in 2014, he presented with class 3 angina with a good LV function, some ECG changes, and he had a no major abnormalities in the biochemistry, non-diabetic, even the LDL is not very high, and he was on good dose of statin, 40 milligram. And let's recapitulate the angiogram at that time. There is a disease in the LAD, which is in the proximal mid-junction, but a diffuse extent in the proximally. So we did a angioplasty, and I got a result at the end like this. I checked the stent boost at that time. I'm not showing you here. Part of the stent was in ostium of LAD, ostium of LAD in the left mid rather, and I flared it also. I can show, I showed it retrospectively, and it was a jetrolima stent 338, which was been post-dilated, and he was being on this medicine after that. So anyway, we had a stent thrombosis, so we have to do something. We did a thrombosuction, we did a balloon dilatation, multiple, and probably more important to see that thrombosuction was done in this case, and progressively higher balloon dilatation was done, and at the end I got a result like this, and I thought that I leave it here with still some clot here and there. The chest pain has settled down. Patient, we took the run of IVUS after post dilatation, and probably we found lot of thrombus, some neointima, but I'll not be able to show you the ostium of the LAD here, but it was clean. So there is a neoatheroma. Probably if you see it, maybe you a candidate for a neo another stenting, but that's a different thing. We didn't do anything. We thought that we'll take the patient afterward in the lab. He developed type 1 respiratory failure, intubated, and then ultimately, this is the ECG when I switched over to single antiplatelet, and this is the ECG. He came, florid anterior MI, and he developed cardiogenic shock. Intra-aortic balloon pump was put. He was been stabilized, and in the meantime, he developed GI bleeding, stopped antiplatelet for 2-3 days, and at the present moment, he is on clopidogrel and aspirin. Now, what went wrong is the stent was underexpanded. It was not a IVUS guided angioplasty possible. Missing the ostium or atherosclerosis, that is also a possibility, or the polymer of the gitronolimus eluting stent, or the aspirin resistance. So although my topic was clopidogrel resistance, but I thought that it is important that many of us, after 36 months of dual antiplatelet, will be cyclically switch over to aspirin, and probably this patient has a platelet reactivity, and suddenly from a severe platelet inhibition, he go into a phase of platelet activation rapidly. And then I finished my talk with a guideline of DAPT 2017 ESC guideline. So what this says that high risk feature of stent-driven recurrent ischemic events are prior stent thrombosis, stenting of last remaining artery, diffuse multivessel disease, chronic kidney disease, at least 3 stent, at least 3 lesion tolerated. Am I audible?
Yeah, you're audible, but the time is over. Can you please wind up?
This is the last one. Of total occlusion. So none of this was appropriate for our case. And at the present moment, we do a DAPT score to look for whether we give a more than 30 months of DAPT or not, 30 months of DAPT or not. So I end here, and I think it's a thought that whether we should do a verify now for all our patients undergoing PTCA, or a long-term clopidogrel or ticagrelor as advised by Srinivas in patient who has a second generation stent. For the latest generation stent, I think we are happy to have single antiplatelet for a short period of time. Thank you for your patient hearing.
So I would request for the speaker to maybe summarize and keep the time, so we have a little bit of time for a discussion.
The last speaker is dwindling role of aspirin and ACS. This would be given by Dr. Mahesh Pulwani.